So I'll introduce myself. My name is Nathan, incoming level 5 BCHB, and I'll be taking you through this session. Okay, a 14-year-old individual experiences recurrent coughing episodes, especially at night, and difficulty in breathing. The symptoms often occur after physical activity and are exacerbated by exposure to dust and strong scents. What is the most likely diagnosis? So type your answers on the chat. Asthma, good. So this is clearly asthma because we have respiratory symptoms and exacerbation by certain allergens. So for example, dust or strong scents. List 3 other clinical features the patient may have presented with. So any other 3 clinical features of asthma other than coughing and difficulty in breathing? Wheezing, yes, wheezing is one of them. Any other? Shortness of breath. Shortness of breath and difficulty in breathing, quite similar, but yes. Chest tightness, yes. Any other ones? So the next one, the one that I'm looking for is the allergen symptoms. So why allergen symptoms? Because the patient has been exposed to these allergens, dust and strong scents. So what allergic symptoms do you expect? When you're exposed to specific allergens? Rhinitis, yes. So that's runny nose. We have sneezing, itching. So most of the time it's usually itchy skin or itchy eyes, watery eyes, nasal congestion. Yes, good. So those are the ones you're going to say. Then one thing to note is the coughing is very persistent and it usually occurs mostly at night. Okay. Outline the exam findings in acute exacerbation of this disease. So for the exam findings, I want you guys to tell me. So this is a patient who has come with asthmatic attack where they have acute exacerbation. So I want you to tell me on inspection, what are you going to see? On palpation, on percussion, and on auscultation. So let's start with inspection. What will you see on inspection? Answers? Nasal flaring, yes. Use of accessory muscles of respiration, yes. So basically, we're going to see signs of respiratory distress. So which are the nasal flaring, use of accessory muscles of respiration, which are usually the sternocleidomastoid, the neck and the shoulder muscles. You can also see visible intercostal retractions. So the intercostal muscles will retract, okay, because they're having difficulty in breathing. Another thing you'll see on inspection, rapid breathing. Yes, good. So the patient will be rapidly breathing. And then another one. So this is after, I can give you a hint. After prolonged periods of difficulty in breathing, what do you expect to see on the mouth, on the mucosa? What do you expect to see on the mucosa? Bluish discoloration of the mucosa, okay? So you would expect to see maybe central cyanosis or peripheral cyanosis when there's prolonged periods of hypoxia, okay? What about palpation? So comment on chest expansion and tactile fremitus. Guys, you know these things. I don't know why you're not typing on the chat. Reduce chest expansion, yes. What about tactile fremitus? Will tactile fremitus be increased or decreased? Mm-hmm. So I'm seeing majority of you are saying increased. So what is tactile fremitus? How we test it is we take our hand, we use the side of our hand at the pinky finger, isn't it? Place it on the intercostal spaces, and then we tell them to say a word like nane nane, isn't it? So that's how we test for tactile fremitus across the chest area, on both sides of the chest while we're comparing. One thing you have to know about asthma, is it an obstructive pulmonary disease or restrictive pulmonary disease?
Obstructive pulmonary disease.
If it's an obstructive, do we expect presence of air or absence of air? What does obstructive mean? Air getting in is okay, but getting out is an issue, isn't it? So we'll expect hyperinflation or air trapping. Now, with that same reasoning, when you do the tactile fremitus, do you expect it to be increased or decreased? A reason like this. How does air travel? You know, you're telling someone to say nane 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 nane. You're feeling for their vibrations, isn't it? So are the vibrations going to be louder or softer? They'll be decreased. Yes, good. So there's air trapping. So we are speaking, it's like a vacuum, okay? So you'll expect the tactile parameters to be decreased. And then another thing is we'll have tracheal tag. Tracheal tag means the trachea is bound to the skin. So when you try and stretch it, you feel as if it's tagged, okay? On percussion,
You expect hyperresonance.
hyperresonance, good. On auscultation,
Crackles.
no. So for asthma, there's a specific sound we hear. It's called wheezing, okay? Expiratory wheezing. So they're usually high-pitched whistling sounds. They'll sound like, don't know if you can hear me clearly, but it's like you're whistling like, ooh, 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 but they're usually at a very high-pitched, okay? And they are best pronounced during expiration.
Yeah.
Okay. So in severe cases, let's say you have a very bad acute exacerbation, you'll have something known as a silent chest. Basically, they are absent breath sounds. Okay. And then what about the vocal resonance? Now, vocal resonance is similar to tactile parameters, but now this time you're using your stethoscope and you're telling them to say nani nani. What do you expect? Will it be increased or decreased? Decreased.
They should be
Good.
decreased too.
Good.
They normally go the same with tactile.
Yes, good. I heard you had mentioned crackles. So for crackles, they're divided into two. We have fine crackles and coarse crackles. So the fine crackles are usually the high-pitched ones, and these ones are seen in diseases like sarcoidosis, asbestosis, and diseases like that, okay? But for the coarse crackles, which are usually the ones that you'll expect to hear, you usually hear them in pulmonary edema or pneumonia, okay? So they have a crackling sound like crack. Those are the coarse crackles. You'll hear them in pneumonia or cases of pulmonary edema.
Interstitial lung disease.
Interstitial lung diseases, you'll hear fine crackles. Okay. Outline the diagnostic workup for this disease.
Yeah. Okay.
Any question? Are you okay?
Yeah, I'm okay.
Okay. Outline the diagnostic workup for this disease. So choice D has a very specific way we answer this question. If you had seen, I think I had gone with it, I'd gone through diagnostic workup with the previous group. But basically how to answer this question, you'll say for the diagnostic workup, or if you're told medical evaluation for this patient, number one, you'll say, I'll take a thorough history. So when you're taking a thorough history, you have to focus on these symptoms that we mentioned above. And then for asthma, very specific, you have to mention if there's any family history of asthma or any other atopy. When I say atopy, I'm thinking things like eczema, allergic dermatitis, okay? Those are the ones that I'm thinking of. And then you have to ask for potential allergens. So in this patient, as you can see, exposure to dust or strong scents and physical activity were their allergens. Okay. And then after you do your thorough medical history, you do a general exam. So on a general exam, in an asthmatic patient, we're interested in cyanosis if it's very severe. Yes, cyanosis is the most important general exam. And then for physical exam, you have to do the respiratory exam, as I had mentioned in C. Okay. And then after that, after thorough history and exam, we now go to tests. So now tell me the tests we are going to do in this asthmatic patient. What is the test of choice for asthmatic patients?
The FEV1.
So it's called spirometry.
Yeah, FEV1 VC range.
So that is spirometry.
Then what about what about eosinophilia? So you do blood count, full blood count, looking for eosinophilia.
Good. So when you
It's
do
not
your
specific.
complete blood count, good, you will check for eosinophilia. Though eosinophilia is not specific, since eosinophils is a marker of a reaction, a hypersensitivity reaction. Hypersensitivity reaction, specifically type 1. But you might find increased eosinophilia. Spirometry, as I had mentioned earlier, you expect FEV1, FEVC ratio to be decreased. Okay. Another test. What about the rest? Type on the chart. Reversibility test using a bronchodilator, salbutamol. Okay, yes. That's also another diagnostic. Any other one? For this reversibility test, do we use a bronchodilator or a bronchoconstrictor? We call it the bronchoprovocation test. I mean, it's rarely performed, but it's one of the diagnostic workups. So what happens is we give a bronchoconstrictor, usually methacholine. And remember, methacholine, what it will cause is it will cause bronchoconstriction of the airways. And then in these asthmatics, when you administer this, they'll have difficulty in breathing. So the airway becomes more hyperactive, isn't it? It becomes hyperactive. So you immediately give a bronchodilator, which is now the salbutamol. So if you give them the bronchoconstrictor and the symptoms get worse, we're going to prove that they're having asthma. Okay, but this one is rarely performed. It's called the methacholine challenge test. We have peak expiratory flow rate. So here we measure the maximum speed of expiration. Okay. Then, as he had said, complete blood count, we'll see eosinophilia. We have skin prick to test different allergens that can trigger the asthmatic symptoms. Serum IgE levels, because we know in hypersensitivity reactions, the levels of IgE are elevated. Okay. And then we have chest X-ray. Chest X-ray basically is to rule out any other infection or any other structural abnormality and under chest X-ray. Okay. So those are the diagnostic measures we have for asthma. Then outline the management for this patient. Guys, you should really check on asthma. I'm seeing people aren't answering at all. So when you're asked about management for a patient, don't rush on pharmacological management, okay? When we talk about management, we can also mention supportive. So we usually start with supportive management, then we go to pharmacological. In supportive management, one thing you should also always remember is patient education. So you have to educate the patient on asthma, its potential triggers, and how they should adhere to their drugs that you give them, okay? When you mention patient education, the lecturer will be like, okay, good. In each and every disease, if you see a question on management, you have to start with supportive, okay? Then you have to teach these patients how to use the inhalers, because there's no use of giving these people the inhalers and they don't know how to use it. Anytime they get an attack, I've seen some people, they'll tell you, oh, how to use this inhaler? They spray on the air, you see, and then they're telling you that's how they use it. So you have to teach them how to use the inhalers. Number two, when you're educating them, you have to educate them to avoid their triggers. So in this case, in this patient, exposure to dust and strong scents. So you should avoid these allergens, okay? So dust, they should clean their clothing and bedding regularly. Strong scents, to avoid them. If it's perfumes or maybe smoke or things like that, you have to avoid them. Okay, so don't rush to pharmacological. You have to start with supportive. The next one is after physical activity. So we can see that this one, it can be related to stress induced, isn't it? So you tell them to avoid strenuous activity. Okay, they have to avoid their strenuous activity. Maybe mild exercise will be good for them. Okay, and then the normal advice you have to give, especially for an asthmatic, to avoid smoking. You know, smoking can be a potential allergen, and smoking generally is not good. Okay. And then we are done with supportive. So under supportive, you can mention around 4 things. Then now you go to pharmacologic. As Bill had said, we usually start with, if you have an asthmatic event or attack, we usually do the short-acting beta agonists. We call them SABA. The most common we give is salbutamol. It's usually used for quick relief, okay? You can also have anticholinergics like ipratropium. These are short-acting. And then we have the controller medication. So the ones I've mentioned, the SABA and the ipratropium, those ones are for relief of the shortness of breath at that moment for an attack. And then for the controller ones, these are the more of the long-acting ones. We have inhaled corticosteroids. Our most common one is budesonide. We have LABAs, which are long-acting agonists, beta-2 agonists. We have salmeterol, and then we have the leukotriene modifiers, montelukast, methylxanthines, theophylline, anti-IgE agents, omalizumab, anti-interleukin-5, reslizumab, mepolizumab, anti-interleukin-4, stroke interleukin-13, dupilumab. Okay, so those are the ones you mentioned under controller agents. These are used on long-term medications. Okay. Then we have oral corticosteroids. So remember the ones I had mentioned earlier were inhaled. Then we have oral. We usually give prednisone. Then we can have combination. So for combination is where we take, maybe for example, an inhaled corticosteroids and a LABA. So usually salmeterol and fluticasone, or formoterol and budesonide. Okay. So the main thing here is when you're asked about management, start with supportive, then pharmacologic. Any question on asthma? I'm seeing you guys have not yet grasped the concept of asthma. It's a very, very high-end topic. You will see it in the wards. Someone will come with acute exacerbation of asthma. You will meet with it during your Viva, you'll meet with it during your MCQs. They usually like asking about asthma. Bill, you had a question?
Mine is sort of a clarification.
Mm-hmm.
So for the asthma, you said we should watch out for the supportive, that is the education,
Mm-hmm.
patient education. Then there is also let them be aware of the allergens and them away. What were the other two?
So educate them on the asthma itself, their triggers,
Yeah.
how to use their inhalers well.
Oh yeah, yeah.
And then depends. So for this one, as you can see, physical activity was one of their triggers. So to avoid that stressor, so mild exercise. And then basically for asthmatic, very high yield for them is they should avoid smoking.
Okay. Okay. Yeah. I think that's now taken care of. Thank you.
You're clear now?
Yeah.
Any other question on this question? So I want you guys to go look up on asthma, very high yield. Okay, question 6. A 45-year-old male presents to the clinic for black stool for the past day. He reports intermittent epigastric pain. A physical exam is unremarkable. Outline the questions you'd ask and the expected answers to confirm he has duodenal ulcers. Okay. Now this should be almost 10 marks because this basically you're taking a history of a patient with duodenal ulcers. What will you ask? That's what the question is asking. And they came in with black stool for one day and intermittent epigastric pain. Okay. Let me see questions on the chat. Okay, let me end your misery. So when you see such a question, basically they're asking you to take a history of a patient who came in with intermittent epigastric pain and black stool. So how to answer this question is, you will Socrates the pain. Okay. After Socrating the pain, you'll ask for the black stool, details about it. Then you go to the risk factors, and then you go to relevant things concerning duodenal ulcer. So if you were to do this, you'd ask, what was the site? We already know site is epigastric, so skip that. We go to onset. What was the onset of the pain? What's usually the onset of duodenal ulcers, the epigastric pain? Is it usually gradual or sudden? It's usually gradual, okay? Gradual onset, because an ulcer does not develop after one day. You just don't wake up and get an ulcer. So it's usually gradual pain. Number two, if you told them to characterize the pain, they'll tell you it's burning in nature. Some will say knowing. Socrates, so R, radiation. You ask them, does the pain radiate? Normally for duodenal ulcers, it does not radiate. Timing of the pain. So for timing, they'll tell you usually starts maybe 2 hours, maybe 2 to 5 hours after eating. Okay. Then you ask, what exacerbates the pain? It depends. Everyone has different exacerbating of pain. So some will tell you certain spicy foods. Some will tell you caffeine, alcohol. Some emotional stress usually exacerbates the pain. Okay. So if you're having stress, reading for internal medicine, that can exacerbate the pain in duodenal ulcers. So it depends. There's no like a specific pain that is written in literature that spicy food exacerbates pain for everyone. No. So it depends with people, okay? Then relieving factors. There are two main relieving factors for duodenal ulcers. What are they?
Food and alkali.
Food, good. So that's how we usually distinguish between duodenal and gastric ulcers. In duodenal ulcers, food relieves the pain. In gastric ulcers, food exacerbates the pain. So how I usually remember, I used to say duodenal desserts. So desserts, so food is good for them, and then they'll gain weight because they always want to eat. For gastric, food is worse for them, so they lose weight because they don't want to eat because they feel very pain. Another one you had mentioned, PPIs, okay? The omeprazole, all those PPIs, you know, they usually offer relief. Then you ask for, we were doing Socrates, A was associated symptoms. Associated symptoms, so I saw Bill had mentioned, you ask about bloating, you ask about early satiety, if it's present, normally it is, bloating is present. Do they feel nauseous? Do they feel like vomiting? Some will tell you they belch, frequent belching. And then postprandial heaviness, where you usually feel your stomach is full, okay? Those are the associated symptoms in duodenal ulcers. And then now, as someone had mentioned, you now start asking about risk factors. Is there a history of NSAID use? We know that NSAIDs cause upper GI bleed, so that is the reason for the black stool. Or is there a history of recent H. pylori infection? Okay. And then you ask, another thing is you'll find family histories there. So maybe the mom had ulcers, the grandmother had ulcers. So you'll see like, it's not really a genetic pattern of inheritance, but they usually a family history aspect for duodenal ulcers. And then you ask about maybe recent weight loss. So for these people, you expect them to have weight gain because they tend to eat a lot since food relieves them. You ask about any change in bowel habitus. Okay. So have you understood how to answer this question?
I have a question.
You just ask the Socrates for the symptoms that they presented. Yes, you can ask. Oh, another one to mention is any drug use like bismuth. Yes, so bismuth, also iron use causes dark stools, black stools. Food, for example, if you eat so much spinach, it also gives you the black stool appearance. Yes. What was your question, Bill?
So, hematemesis, which condition do you normally find hematemesis apart from the esophageal, like say varices, the esophageal ones? Ulcers, is hematemesis common?
Yeah, that's also
Which
because
ulcer?
hematemesis is a sign of maybe upper GI bleed.
So
Normally,
we
it's
can
usually
do just stomach ulcers,
it
the
depends.
gastric
Normally,
ulcer.
it's usually gastric. It's usually gastric ulcers. Okay. So they'll present in hematemesis.
Yeah.
Another one people also forget is mallory tear. In mallory tear, you have rupture of the vessels that supply the esophagus. Okay. So this is due to maybe chronic vomiting. And you know, when chronic vomiting happens, it erodes the mucosa of the esophagus. So they usually present with hematemesis. Normally very common in alcoholics, mallory tear. It's called longitudinal laceration of the esophagus. Then we have ulcers as another cause of hematemesis. We have the one you've said, rupture of esophageal varices, normally due to portal hypertension. Okay. It can also be due to trauma. You know, trauma can occur, and then you can have hematemesis. Have I answered your question?
Yeah.
Okay, good. So are we clear with A? Okay, we go to B. What diagnostic approach would you take for suspected duodenal ulcers? So I told you how to answer this question. Diagnostic approach. So what do we start with?
Complete blood count, searching for anemia.
I told you, when you see this question, you don't just rush to labs.
History.
You have to say, you take a thorough history,
History,
do a
physical
general exam, and a systemic exam. So on history, we have talked about it. On exam, what are we looking for? Signs of tenderness, because we have epigastric pain. And then they're losing blood. So we're going to check signs of anemia. Will they have pallor? Okay. And then now you can rush to your tests. You were saying complete blood count?
Yeah, for the anemia.
So low HB.
So you expect anemia. Then you can also do.
What is the gold standard for a patient with duodenal ulcers? How do you diagnose them? Have you ever heard of an EGD? Esophagogastroduodenoscopy or OGD?
Yeah, I've seen one being done. It's normally the most common being done. But is it expensive or might just go for it?
That is the gold standard for diagnosis for ulcers. You have to visualize and see where the ulcer is, because you cannot know if it's duodenal or, yeah, apart from history taking, we have to know. Plus, we also visualize to check if it has become malignant. Okay. So OGD, we start from the mouth, it goes to the esophagus, to the stomach, then to the duodenum. Okay. And then another test. So we have said complete blood count, OGD, another one. The rest, what are you guys saying? So gastrin levels, Zollinger-Ellison syndrome is a very rare cause of ulcers. But you can also test that. We have H. pylori testing. So H. pylori testing, there are two ways we usually do it. In fact, there are three. Number one, there's the urea breath test. We know that H. pylori produces urea. So we usually tell them to ingest. So, okay, the people who have been done for, they ingest a urea solution and then they breathe it out. Then we check the level of carbon dioxide in there. And then the most common that is done is the stool antigen test. We usually detect H. pylori antigens in stool. And then we have biopsy. So remember, when you're doing the OGD, we usually go and biopsy to check for if there is any malignant change. Okay. Then in case you think there is a perforation, you can do a CT. Okay, those are the tests we can do. Mention 3 complications of duodenal ulcers. They're usually 4. So what are the complications? 4 direct ones. GI bleeding, yes. Perforation, obstruction, and then finally, malignancy. That is usually the order. They bleed, then they cause perforation, which may lead to an obstruction, and finally they become malignant. Okay, so any question on this question on ulcers? Maybe before we continue, we can do a difference between gastric ulcers and duodenal ulcers. Number one, we said food. In relation to food, duodenal, think of desserts, so it decreases with meals, or it is relieved with meals. Gastric, it is greater with meals, so leads to weight loss. Duodenal leads to weight gain. Another cause for gastric, which is most common, is NSAIDs. For duodenal, Zollinger-Ellison syndrome. Okay, and then the risk for cancer usually increased in gastric, but for duodenal it's usually benign. Okay, nocturnal pain, this is pain at night, more common in duodenal ulcers, less common in gastric ulcers. And then dominant blood group, gastric ulcers usually blood group A, duodenal blood group O. Is it okay?
Yeah, that's okay.
Okay, the last question. A 23-year-old female presents the clinic with a 2-week history of intermittent fevers, fatigue, and weight loss. On further questioning, he mentions that he was diagnosed with rheumatic fever 3 years ago, which required hospitalization. Additionally, he underwent a tooth extraction 3 weeks ago. His physical examination reveals new heart murmur, small tender nodules on the pads of his fingers and toes. What is the most likely diagnosis? Well, this is very, very, very direct. What is the most likely diagnosis?
Infective endocarditis.
IE. Good. Infective endocarditis. Which microorganism is most likely responsible for this presentation in this specific patient?
Streptococcus pyogenes and Staph aureus, the highly virulent ones.
No.
Okay.
Any other try? Streptococcus viridans. Yes, that's the answer. So I'll explain. I'm going to explain. Let's continue. Outline the criteria used for diagnosis. So which criteria do we use for infective endocarditis?
Jones.
Jones? No. Dukes. We call it modified Dukes criteria. Okay. Jones, you're confusing. Jones is used in rheumatic fever. Modified Dukes is used in infective endocarditis. Let me send you guys a picture so that we follow through. The formula for the criteria, the modified Dukes, how I used to remember, you say B timer. Okay. So BE are the major criteria, then timer is the minor criteria. Can anyone see that? Everyone can see that image? Okay. So B, blood culture positive. So when we say blood culture positive, what do we mean? We mean that you have to have positive for the typical microorganisms that cause infective endocarditis. And we usually take these samples from 2 separate blood cultures. more than 12 hours apart. Okay, so the bacteria that are common are Strep viridans, Staphylococcus aureus, Enterococcus. Those are the main bacteria that cause infective endocarditis. So they have to be positive for you to qualify for that major criteria. Number 2, BE. E is echocardiograph evidence of endocardial damage or involvement. So the echo findings that you're going to see, number 1 is presence of vegetations. Okay. So these bacteria are going to form vegetations on the valve. So that is what you're looking for under echo. So it can be vegetations, it can be abscesses. You can also see valvular regurgitations. Okay, so those are the two main things you look on echocardiogram. The next one is the minor criteria, timer. So T, temperature greater than 38 degrees. So they must have a fever. Okay, it's not that they must have, but that's one of the minor criteria. I is immunological phenomenon. So under immunological phenomenon, we usually have immune complexes setting on different parts of the body. So Osler nodes are the ones that settle on the fingers or the toes. Rot spots are the ones that settle on the eyes. Okay. It can also settle on the kidneys, causing glomerulonephritis. Those are the immunologic phenomenon. Microbiological evidence. These are positive blood cultures that do not meet the major criterion. Okay. So for example, if you culture and you see a certain bacteria like Coxiella, so it does not meet the criterion A. And then we have embolic phenomenon. So embolic phenomenon is, how I'd remember it is, you know what happens is, after vegetations have been formed on the valve, these vegetations, since the heart is pumping at high pressure, the vegetations can be dislodged. And now when they're dislodged, they get dislodged in different areas in the body. Okay. So examples are, it can go, if it goes to the brain, it can cause a stroke. If it goes to the kidneys, it can cause an infarct or glomerulonephritis. If it goes to the spleen, it can cause an infarct. So different areas where these vegetations will be dislodged. And then R is for risk factors. So risk factors include IV drug use, congenital heart diseases. So the risk factor in our patient here is, number 1, they had rheumatic fever 3 years ago. And number 2, they had a tooth extraction 3 weeks ago. So those are their risk factors. So what happened in this patient is they had a tooth extraction, and the most common normal flora in the teeth is Strep viridans, and they had rheumatic fever 3 years ago. So meaning their valves are already defective. Now what happens is when they had the tooth extraction, the Strep viridans went, got into blood, it reached the heart, started forming vegetations. And that's how they got infective endocarditis. Okay. So for the bacteria, something to explain is we have subacute and acute causes of infective endocarditis. When we mention acute, we mean that it has very high virulence. Okay. So the most common cause of acute infective endocarditis is Staphylococcus aureus. And in Staphylococcus aureus, it is very rapid and you get it regardless if you had a valve pathology. So you might be just a healthy patient, you have no valve issue, then you get infective endocarditis. We'll know that the bacteria responsible is Staphylococcus aureus. But in subacute, it usually has a gradual onset and it is caused by bacteria that have low virulence. For example, Streptococcus viridans. Okay. And it is found in patients who have defective valves already. For example, if you had rheumatic heart disease, or if you had a congenital anomaly when you were young, let's say you had a PDA, or maybe truncus arteriosus, all those congenital anomalies that you know. Okay, and it's usually a sequel of dental procedures, like in this patient. So have you understood the difference? Acute, high virulence, Staph aureus, rapid onset. Subacute, Streptococcus viridans, low virulence, gradual onset. Defective valve. So in a patient also with a valve, a prosthetic valve, they will fall under subacute. So these are people who have defective valves already. So vegetations will form there. Okay, have you understood the difference? Okay, list 4 systemic manifestations of the disease. Yes, so this is easier. I've made it simpler for you guys. Under embolic phenomenon, splinter hemorrhages, genuine lesions, septic embolism. So anywhere these vegetations go and dislodge. Then under immunological phenomenon, we have rot spots, oslar nodes, glomerulonephritis. Okay. So you mention any of those. There are so many. Can't miss to get 4. Okay. Another one under immunologic phenomenon, we have rheumatoid factor. It's usually present in infective endocarditis. Okay. Then under embolic phenomenon, we also have mesenteric emboli. In mesenteric emboli, what happens is emboli goes to the mesenteric vessels, and we know the mesenteric vessels are the ones that supply the GI system. So it can come with abdominal pain. We can also have coronary emboli, where it goes to the coronary arteries, and the coronary arteries are the ones that supply the heart. So they'll come in with symptoms of myocardial infarction, acute chest pain. Okay. And then mention 3 investigations you'd perform on this patient. I've talked a lot, so you guys tell me. Some are in the modified Duke's criteria. So okay, good. So blood culture, as we had said, you have to take 2 samples, 12 hours apart. Echocardiogram, complete blood count. Checking for anemia. Remember, it's an infection, so you might have leukocytosis. And then inflammatory markers, we have CRP, ESR. And then remember, we said that in infective endocarditis, it can affect multiple systems. So if it affects the kidney, we have to do urinalysis to detect hematuria, because it causes glomerulonephritis. So when you're doing urinalysis, remember you do urine microscopy to check for the presence of red blood cell casts. And then we have chest X-ray to check for pulmonary involvement. Okay. I think we are done. Any question?